Patricia Gibson is an associate professor in the neurology department at Wake Forest University School of Medicine, where she provides individual, group, and family counseling and is actively involved in medical student, nursing, patient, and community education. She also serves as the director of the Epilepsy Information Service, a nationwide telephone information line for patients and their family members in operation since 1979. Ms. Gibson received her Master's of Science in Social Work degree from the University of Tennessee in 2012. In 2012, she was awarded an honorary doctorate in humane letters from Queen's University in Charlotte, North Carolina. Ms. Gibson has organized and conducted numerous state, regional, and more than 40 national and international conferences on epilepsy. She set up the Epilepsy Medication Fund for the state of North Carolina in 1987 and conducts numerous fundraisers for this fund. She has received national and international awards for her work to improve the care of those with epilepsy. She presently serves on as the volunteer executive director of the Epilepsy Alliance of North Carolina. And we are just so happy to have her here today to talk a little bit about the topic and how it relates to brain injury. And so if Pat, if you will share your screen.
Okay. Well, I first want to thank you for inviting me to speak. It's a real honor to be with you, and I have a great deal of interest in seizures and head injuries, and I do take a lot of calls in regard to that. I'm going to start out by seizures and head injuries. I have always had an interest in seizures and head injuries since that's one of the more common causes of seizures in adults. These are our objectives. I will be using new terminology. These are my disclosures. I do serve on the UCB Scholarship Committee, and I would recommend any of you interested in going to college to please submit applications. We give away 40 scholarships, and about 5 or more of those are for family members, siblings or even parents who want to go back to school. And we have the Epilepsy Alliance America has, for the first time, developed a scholarship for non-epileptic seizures, which we will commonly see in people with head injuries. And I would encourage you to please let others know about this. Laura and I will be sending you a copy of that to put on your website. We're very eager to reach a lot of people, letting them know. To my knowledge, this is one of the first scholarships in our country for non-epileptic seizures. I began as one of the original comprehensive epilepsy programs that was set up as a role model for how to treat epilepsy. One of the first 3 was set up at the University of Virginia under the direction of Dr. Fritz Dreyfus, and this was made possible by an NIH grant thanks to the work of Dr. Kippen Penry. All of these programs had 3 main areas of research, education, and direct services to patients. When I got to, Dr. Dreyfus actually wanted to do a more regional program and include North Carolina and part of Tennessee. He sent me to North Carolina to develop that part of the program. When I got here, and this was in the early 70s, long before the time of the internet, I realized that many people with seizures had very few ways to get information. There were almost no books in the libraries. Patients weren't told a lot of things by their physicians. And there was not actually a lot known about epilepsy at that time. So I decided to open up a toll-free telephone number, originally just designed for North Carolina, but one day they came and worked on my phones and opened me up to the nation. I've actually taken about 500,000 calls on this line from persons with epilepsy or close family members. And it is those people who have taught me what I know most about epilepsy. And it's interesting that even though I do no publicity of this line, I get calls not only from across the nation, but even other countries. And I have no idea how they find out about us. I track the calls and concerns of people with epilepsy and look at what are the issues. And I try to take this information and advocate on behalf of those patients and family members to try to see that we can set up what is needed. And I'll be talking more about this at the end of, near the end of the meeting. Oliver Wendell Holmes once said, "If I wished to show a student the difficulties of getting a truth from medical experience, I would give him the history of epilepsy to read." And I can tell you that epilepsy is a very complicated disorder that has been very misunderstood throughout the years. And many people with epilepsy in our history have been treated very poorly because of the ignorance and misunderstandings out there. A seizure, the official description is here. Basically, a seizure is just a symptom of an underlying brain problem. And depending on what that underlying brain problem is, will determine what form the seizure takes and how serious it is. But it's just another symptom. And for people with head injuries, like most people with epilepsy or ongoing seizures, that symptom is only one of many. When we say that someone has epilepsy, it simply means someone who has a tendency for recurring seizures. That's all it is. If you have a tendency for recurring seizures, you have epilepsy. One seizure does not make for epilepsy. You really have to have more than one unprovoked seizure to be called having epilepsy. Epilepsy takes place in the neural network. It is a problem in the neural network. It may be a problem in the terminal. It may be a problem with the neurotransmitters, the receptors, but this is where it all takes place, that dysfunction, that misfiring, that something just doesn't work right when the brain is going about its business. This is a slide that shows the incidence of epilepsy. And as you can see, the most common times to develop seizures is birth to about 10. It levels out somewhere between 20 to 50 or 60. And then after the age of 60, that line goes straight up. So the most common groups of having epilepsy are the very young and the very old. But any of us at any time can develop seizures. This slide just shows you the different etiologies at different ages. What's more common when you're young, infection, for instance, or malformations. And then as you get older, we see more problems with brain tumors or vascular disease. Of course, head injuries can occur at any of these ages. Here's some basic statistics. 1 in 10 of us will have a single seizure and will not go on to have ongoing seizures or epilepsy. 1 in 26 of us will develop epilepsy. And as I said, any one of us at any age, for any number of reasons, head injuries just being one of those, can develop epilepsy. Older adults account for approximately 25% of the new cases each year. The incidence of seizure increases dramatically after age 60, and by age 80, 1 in 4 of us will have seizures. In approximately 60 to 70% of the cases, we can't tell you exactly why you develop seizures. And approximately 50 to 60% of all people respond to the very first medicine, with another 15%, responding to an additional medicine. But we still have, with all that we have, about 25 to 30% of people with seizures that have ongoing seizures or what we call intractable seizures. We just don't have a really good answer at this time. We're working on it, and some of our new developments just this year, I'm hoping are going to make a difference and cut that number some. And certainly head injuries is one of the leading causes of seizures in adults. 1 in 10 people with a traumatic brain injury will develop seizures, and usually within the first 2 years. Interesting that only 9% will have a seizure while in the hospital. Seizures, you need to know, can develop immediately or even months to even years later. And penetrating head injury, such as a gunshot wound, has the highest likelihood of causing seizures. Those with pre-existing conditions are at the highest risk. The people who already have some kind of brain problem and then have a head injury are really at high risk. For instance, if they already have cognitive issues or emotional disorders or memory problems or attention deficit problems, a head injury only makes those things worse, which just makes common sense. It's the same way with epilepsy. For those people who develop epilepsy, who have these issues, it's often turns out to be a more difficult form of epilepsy or a more difficult time treating it. For those who have a seizure more than a week following the injury, a head injury, 80% will go on to have seizures. Half of those will have seizures ongoing for life. The good news is that half of those seizures are going to be easily controlled and may even go away at some point. Most will be controlled with medication or other treatments, depending on the severity of that injury. You need to know that there are conditions that mimic seizures. So we sometimes have a hard time diagnosing seizures because there's a lot of conditions that look like seizures. Hyperventilation, anxiety, overbreathing, and can trigger symptoms that look like seizures. Migraine. A lot of people who have migraine have symptoms that are very similar to focal seizures, and sometimes we have a difficult time determining, is this a migraine or is this a focal seizure? Panic attacks can have symptoms that look just like seizures. They can take a lot of different forms, but these often last a whole lot longer typically than an epileptic seizure. And usually there's no loss of consciousness with this. Psychogenic seizures often present the most difficult time for determining which is which. And these seizures, or non-epileptic events, as we call them, come from some major trauma, emotional trauma, or some difficulties. In fact, the young woman who won her scholarship last year developed non-epileptic seizures that looks just like epileptic seizures. And the underlying cause for her is that she had had 32 surgeries to her chest and had a post-traumatic stress syndrome. And part of her symptomatology was to have these non-epileptic events that look just like epileptic seizures. Syncope is another condition that mimics seizures. Fainting episodes can often have tonic-clonic looking movements, but it's coming from a different mechanism. TIAs, transient global amnesia, and transient ischemic attacks are two other things related to stroke that sometimes look like seizures. For people who have a tendency for seizures, there are certain things that will cause their seizures to come on. They're precipitating factors. And number one is missing your medication. Your brain has to have a constant flow of anti-seizure medicine going into it in order to protect from seizures. And when you miss your medicine, that level of medicine drops in the brain, and you can easily have a seizure. And this is actually the number one reason that people have seizures that are on medicine. Another real biggie is sleep deprivation. And I cannot tell you how important sleep is for all of us, not just people with epilepsy, but especially so for people with seizures. Sleep, we have just found in recent years how important this is for laying down memory. If you do not get adequate sleep, your brain does not have a chance to cleanse itself and get rid of the toxins. Because when you sleep, when you reach a certain stage of sleep, your brain cells actually uh, shrink and a fluid comes out and washes over the brain and picks up all the toxins in the brain and sends it back down through the spinal cord. We've just found this out in recent years, and they're now beginning to see some connections with many of the problems that people are having who do not get adequate sleep. And certainly memory problems is one of the big ones. They're even looking at perhaps there's some connection with lack of sleep and the development of cognitive problems or development of you know, Alzheimer's disease. A lot of research going on in regard to this. I wish I had known what I know now about sleep. I would have been much more careful to get adequate sleep throughout my life. And with people with epilepsy, it's crucial. In fact, if we're not seeing what we want when we bring patients into our epilepsy monitoring unit and we're not picking up what we need on EEG, we will often sleep deprive them, have them stay up for 24, 48 hours, and then we're more likely to see the abnormality. Sleep deprivation is also a real biggie for car accidents because it causes people not to be attentive. And 1 in 8 of us will be in a car wreck in a year. Each year, 1 in 8 people will be in a car wreck. So sleep is really important for um, attention and helpful in driving. Hormonal changes can make a difference in terms of seizures. A very high level of estrogen is pro supportive of seizures. So a lot of times, when the estrogen peaks too high, some people will develop what we call catamenial seizures. And this is an issue, especially with teenagers as they go through hormonal changes. There is a big uh, promotion of seizures by the use of alcohol. In fact, alcohol lowers your seizure threshold, as does a lot of the recreational drugs that we use. And it's not just all the illegal drugs, although they're really good for causing seizures. Cocaine, heroin, all of those drugs, marijuana that has high levels of THC can precipitate seizures and make people have a tendency for a lot more seizures. Vaping has recently been recognized as a precipitator of seizures, and I'm starting to get calls from parents of young people who develop seizures upon their initial vaping, because vaping, the tobacco pod in vaping has a much higher level of nicotine, and high levels of nicotine is toxic to the brain. So we're starting to really see a lot of problems with vaping. It's actually much worse for you than smoking a cigarette. Another thing that we're finding problems with is the high level of energy drinks, the Red Bull, and I don't know what some of the other names are. We're starting to see seizures being caused by those drinks for the first time, even in someone who has a tendency for seizures but never had one, or for those with already diagnosed seizures who are turning to energy drinks to, be more awake. We're seeing them develop more seizures. It's not just the illegal drugs that do this. It can be regular other drugs too. There's some drugs, for instance, some of the antidepressants like Wellbutrin will lower the seizure threshold. Some of the asthma medicines will lower it. And then sometimes there's drug interactions. There's certain antibiotics that with certain drugs will lower that drug's level that can make for a seizure. Um, Stress is also a biggie. Stress changes all of us. If you get under stress, you may develop more infections, you may have more headaches. Stress, there's a really big connection between the mind-body interaction. And stress causes different physical symptoms in all of us. And with seizures, if someone gets under a lot of stress, it can also make them more prone to seizures. So learning good stress reduction coping mechanisms is really important for people with seizures. Excessive caffeine that goes along with the energy drinks can also make for more seizures. And then certain nutritional deficiencies like low calcium, low magnesium, low blood sugar can all cause seizures as well. In some people, not all people with epilepsy, they have specific stimuli that will make their seizures worse. There's some people with epilepsy that a certain frequency and color of flashing light will do it. In fact, if you've ever had an EEG, that's one of the things we test for. We will do flashing lights on you when you're having the EEG to see if we can precipitate a seizure. It can be very unusual stimuli, but this is more rare, not as common. Certain, characteristics of seizures are they're always episodic, they're often sudden and unexpected, we can't predict them, they're very often stereotypic. That means it will always be the same way. The head may turn to the left arm may go up, the body twists around. It will tend to be always the same way, that episode of behavior. And it can be variable in intensity. In the early 80s, Dr. Dreyfus and a group of cohorts came up with an international classification of seizures. And they basically are broken down into two main areas. There are generalized seizures, which start up all over the whole brain. And then there's partial or focal seizures that come from one spot in the brain. The problem in the brain is coming from one little area. Then when you're doing classifications, you always leave an unclassified group. And they put status epilepticus into a separate category. And this simply refers to having one seizure after another after another. This condition is called status. And when this happens, this is an emergency situation, and that person probably needs to be taken to the hospital or at the very least given a rescue medicine. And we'll talk about that later. In the generalized seizures, these are the list of generalized seizures. These seizures come up from the brain, the whole brain all at one time. The whole brain is infected, and I'm going to go over these with you. Absence, you probably won't see many of these associated with head injury. These are very brief staring spells. And I say it's spelled just like absence. We tend those of us who are older use the terminology. This was absence seizures were discovered by the French doctors, and we use their pronunciation. This comes on typically in childhood around the ages of 5 to 10. It's very brief, short loss of consciousness. It's as if I could reach inside your brain, flip a switch, turn everything off, and then 10 seconds, 20 seconds, 30 seconds, reach back in, flip that switch on, and you're back on. You will not know anything that happened during that 15, 20, 30-second period of time. You will be back to normal immediately. These tend to be inherited, but the person has no memory that they've had this. And so this is often missed. Sometimes it's picked up by the school teachers. But many of these kids get branded as being daydreamers or dummies or not paying attention, and it can be overlooked and maybe be a while before it gets diagnosed. Tonic-clonic seizures. Tonic means stiffening and clonic means jerking. This is a seizure that most people think of as the convulsion. An old term is grand mal seizure. This seizure is the one that most people think of as epilepsy. And it is not the most common type of seizure, by the way. You may be standing when all of a sudden you just have a total loss of consciousness and you fall to the floor. Your muscles will get very rigid. This is the tonic stage. All your muscles will get very rigid. If your tongue happens to be in the way when this happens, you may bite it. You may even turn a little blue. The tonic stage doesn't last very long, and then the body goes into the clonic stage, a rhythmical jerking. This seizure typically lasts a minute, minute and a half. It can go longer, but typically it doesn't last long. If you have a full bladder, when that tonic stage hits, you may lose control of your bladder or even bowel. After this seizure is over, there is almost always a confusion, post meaning afterward, ictal referring to the event, a post-ictal confusion. You don't just jump up and get back to normal. You are exhausted. It's like having the worst workout of your life. And you're very tired and groggy and need to sleep. That's a typical tonic-clonic seizure, and we'll talk about first aid in just a minute. The myoclonic seizure, all of you upon going to sleep have probably had your arm or leg do a little kick or a little jerk. That's actually a muscle myoclonus. Your muscles are sort of shutting down. But when we talk about a myoclonic seizure, we're talking about something that originates in the brain. It's a brief, shock-like little muscle contraction, usually involving the head and the upper extremities, waist up. You'll have just sudden little jerks of the hands or arms, the head. You'll often see this seizure upon awakening or upon falling asleep. And sometimes this seizure doesn't usually just occur all by itself. It usually comes with additional seizures such as tonic-clonic. But it's a common seizure that some people have. Atonic, A meaning loss of, tonic referring to tone, is a sudden drop attack. The person is just standing there and wham, they hit the floor and they hit it hard. And these are the people that you may sometimes see wearing helmets because they have a lot of head injury just from that fall. The atonic seizure, they have impaired consciousness immediately, but once they hit, they're back, their consciousness is back. And the biggest problem with atonic seizures are the injuries. It's very brief, but the injury can be considerable. We had a beautiful little redheaded boy a few years ago who was in our clinic standing by the desk, and the doctor was looking into his eyes and checking things in his eyes when that little boy went into an atonic seizure and he just suddenly dropped. But on the way down, the corner of the desk got his head, his scalp, and made a pretty good gash. And we had to rush him down to the emergency room for some stitches. And when the ER doctor was stitching him up, he said, "My goodness, son, what happened to you?" And that little boy said, "That doctor hit me." And it was the first time that I realized that, a lot of these kids may think they don't know what happened to them. They're standing there next to you and all of a sudden they're in the floor. I mean, you must have hit them. And it was at that time I realized how important it is that we talk to the kid about what is happening here, because they may have some ideas about that are not accurate. The focal seizures or partial seizures are coming from a particular spot in the brain. And depending on where that spot is, will determine what the person does in their seizure. For instance, if it's back in the back part of the brain where sight is involved in the occipital lobes, that seizure is going to involve visual changes. And if it's over here where smell is in the temporal lobes, where smell is, they're going to, as a part of their seizure, they may smell something different, smell something usually unpleasant as a part of their seizure. So anything the body can do can be a part of that seizure activity. So partial seizures have many, many different symptoms and can often not be recognized as a seizure. There's two categories of focal seizures. There's the simple focal seizure or that has no loss of consciousness. I could stand here and talk to you and have a focal seizure. It may start up there in my motor strip. And if that's the case, what will happen? I would be talking to you, and all of a sudden my thumb may start to jerk. My whole hand may start to jerk. It's in the motor strip that makes for motor movement. Or it could be somatosensory. I could feel something. For instance, one of my patients feels someone touch her on the back, and that's the beginning of her seizure. It may be autonomic. It may be a funny feeling in the stomach that rises up. It may be psychic. I have some patients that have feelings of deja vu or jamais vu. I have one patient that hallucinates. She will see, that tells me that she's got problems in the occipital lobe where vision is. She will see things on the wall. She will see cartoons that are not there. And that is the beginning of her seizure. So this, you can have this seizure and be fully conscious and aware that you're having it. The most common seizure of all is the complex partial seizure, or the focal with impaired consciousness, the new terminology. These people will go into a seizure, and it can vary tremendously in what it looks like. But they are not completely there. They have what we call clouded consciousness. I may be sitting here and talking to you when all of a sudden I may just go into a stare. My head may turn to the right. My right arm may go up in the air. I may twist around. I may even stand up and start to walk around. And I will typically have automatisms of lip smacking, chewing movements. I may pluck at my clothes. I may be fumbling with something on the desk. And this seizure can last longer. This one may go on for several minutes. But just a staring spell does not make absence seizures. It can be a focal seizure as well. But this seizure can take so many different forms. One of my patients, his seizure is he jumps up, he snaps his finger, he twirls around, he snaps his finger, and that's his seizure. So many different forms, this seizure. And this one is often misdiagnosed, and people thought to be on drugs or having, psychiatric problems because they're acting so weird. But this is the most common seizure out there. A focal seizure can switch over. It can start simple and go to a more complex seizure, or even evolve into a full tonic-clonic seizure, and that may go rapidly. I mentioned non-epileptic seizures, and in our monitoring units, about almost half of our patients turn out to be have not epileptic seizures, but non-epileptic events. And it is really hard to tell the difference unless you hook someone up to an EEG when they're having the event. And there are people who have both, which makes it even more confusing. And as I said before, this is not an uncommon problem with people who have especially mild head trauma. And I could do a whole talk on just that one topic. The risk with seizures is pretty obvious. Seizures can result in injury. There can be seizure emergencies, although these are rare. They can be life-threatening. Anyone who has an ongoing seizure that's not stopping, fairly quickly needs to be treated right away. Most seizures just run their course, and they are not not an emergency. Typical seizures just happen and they last less than a minute or a minute and a half, and they're over. But you want to have a very rapid response and know what to do in a seizure, and especially seizures that are going too long or keep on, coming in and out of seizures and having what we call clusters of seizures. Everyone with seizures should have a seizure action plan made with their doctor as to what to do when you go into a seizure. The caretakers need to have this plan The patient with this needs to have a plan and let all those around them that are likely to be with them when this happens be aware of what to do and to have a formal seizure action plan. In schools, it is required for each child with seizures to have a seizure action plan. If anyone needs a copy of one of these, I'll be glad to provide it. In terms of first aid, you do not give anything by mouth until that person is back to normal. As I said, most seizures are not emergencies, and basic first aid depends on whether there is a change in awareness or loss of consciousness. That makes all the difference in the world. Some seizures people will have and you won't even know they had them, so you don't need to worry about first aid. A tonic-clonic seizure, the convulsive type of seizure, one of the key things when someone falls, if you can, try to protect them and protect them from harm. Cushion their head. If they're on the concrete floor, put something under that head. Remove harmful objects. I've actually had patients stand and watch my patients. One broke his ankle because he was banging his ankle against a metal desk leg. Another one was banging his head against the concrete wall and nobody did anything about it. So you want to try to protect their head, especially. You want to make sure their airway is unobstructed. It is very helpful to turn the person on their side and preferably left side when you can roll them over, because a lot of people will get a lot of saliva in their mouth and that needs to drain out. Rolling them to their side, that is very helpful for that to drain out. And you want to make sure their head is in neutral position, not all bent down and in a way that could prevent breathing. You want to time that event. You want to, because I'm here to tell you that when you're trying to judge by yourself an event that is very frightening, it is really hard to judge in terms of time. So you want to look at your watch or look at your phone and see what time it is, because one of the questions we're going to ask you is, how long did that seizure last? And you want to know, how long is that seizure lasting? Do not put anything in the mouth. Now, when I was growing up, we were told really dumb things. We were told you need to put a spoon in the mouth. That is not helpful. You can break teeth. I've had people put all kinds of things in people's mouths, things that almost choke them. So do not put anything in the mouth. If they're going to bite the tongue, they've already done it before you can do one thing about it, quite honestly. Do not try to hold them down. Do not try to restrain them. I've had people jump on patients and try to keep them from jerking. That is not helpful. And you want to stay with that person until they're fully conscious and follow the seizure action plan. You want to try to get people back away from them. Nobody wants to wake up from a seizure and see a herd of people staring down at them. You want to do common sense kind of things. And explain to people, he's having a seizure, she's having a seizure, everything's going to be okay, and handle the situation. Pretty simple first aid. If that person has a VNS, and I'll talk about that in a minute, you may swipe. They should be wearing a magnet, usually on their wrist, and you can swipe that magnet over their VNS in the chest, and that can be used anytime in the seizure. Rescue medication can be prescribed after a specific number of seizures or after the length of a seizure or change in pattern. We now have rescue medicines that we can give at home that can stop the seizure before the rescue squad gets there, or you may not even have to call a rescue squad, being able to use this rescue medicine. You always refer to the person's action plan for what to use and when to intervene. A focal seizure without loss of consciousness, that person is fully aware, and all you do is stay calm, time that seizure. That's helpful to them. Reassure the student or person that they're safe, and explain to other people if you need to, and protect the student or person's privacy. Nothing much to be done in someone who has full consciousness. In a focal seizure with impaired consciousness, it's very important not to grab that person, not to speak loudly. I've seen so many people making mistakes, even some professionals. They'll go up and try to grab the person, try to hold them or something, and they'll, for some reason, tend to talk really loud to people in a seizure. Speak softly and calmly. If they're up walking around, which they often don't do, but if they are, you just sort of guide them from the back away from any harmful objects. But you allow, for the most part, let them walk around as long as they're not getting ready to walk out in front of a car or something. If the event lasts beyond the routine, or another seizure starts to follow up after they've had one and it's starting up again, then you follow the emergency protocol. As I said, don't restrain, don't grab, don't shout, and don't expect any verbal instructions to be obeyed. After one of these seizures, it takes a while for that person to come back to normal, and they may be confused for a period of time after this seizure, and it is not helpful. I have watched this with one of our emergency teams come in and talk to a patient screaming at him for some reason and asking him questions way before he was able to answer. And that only upsets and scares people. You know, it's sort of like if you woke up in the middle of the night and you had a lot of people around you trying to touch you or hold you or something and talking real loudly to you, how would you feel? I don't know about you, but I'll try to take out a few with me. And so it often happens that they may hit at you if they think you're trying to hurt them. They don't know who you are, even if you're their mother. A tonic-clonic seizure in a wheelchair, do not try to move them from that wheelchair because people in a seizure are really hard to move and they can be very heavy and uncooperative. And, you know, don't move them unless absolutely necessary. Just secure the wheelchair to keep it from moving, fasten the seat belt, you know, protect and support their head, and, you know, and especially watch their legs because those metal foot holders can be a problem, and you can put things in a shirt or a coat or jacket or something to keep them from hitting that. Or move it back out of the way if that's possible, and then just follow your typical first aid. In water, you want to place that person on their back and support their head so that the mouth and nose are always above the water, and get them out of the water as soon as you can. If the person is not breathing, you begin rescue breathing, and always, so we recommend supporting the person to the ER, especially when water is involved, because you can get water in the lungs and that can present problems. So we take those on to the emergency room, even if they are back to consciousness. I've noticed in one of the write-ups about first aid for seizures and head injuries that they recommended that if this is the first seizure after a TBI, to call the person's doctor for advice. And also, they recommended that if the seizure doesn't stop after 3 minutes, to call 911 and to start CPR if there's no pulse, of course, calling 911. Many of the guides say 5 minutes. A lot of it depends on where you are, how far away you are from rescue squad, but in many cases, the person will have rescue medicines. And if they don't have, they can ask their doctor for those. While most seizures do not cause a problem, there are some seizures that can be dangerous, and people can die during a seizure or due to complications from a seizure or from status epilepticus, having just constant seizure activity. And usually this comes on when there is a very bad underlying problem in the brain. A common form of death related to seizures that we don't quite understand is SUDEP, sudden unexplained death in epilepsy. We just don't know what's causing that. There's obviously a cause. I want to point out that there's also sudden unexpected death in people without epilepsy, in people who have no problem. People have been known to die, and we cannot find a reason. There obviously is a reason, but sometimes we just don't know what it is. And there's lots of research going on now about SUDEP. I have some tips that I think are really important. If you or your child, I would advise you to keep you or your child's medical summary with you at all times. You never know when you might end up having to go to the emergency room, and it is so helpful to have a complete write-up, a summary of your situation. I would keep extra copies. Actually, all of us should do this. You never know when you're going to be in a car wreck, and it'd be really important for them to know certain things about you. It saves times and it prevents mistakes. You've got the medicine down as exactly how it's being given. They will know that you're supposed to be on this medicine. Very important information. You may not be able to give it to them, but if you have it on your person, that will be very helpful. I also recommend wearing those emergency, bracelets that tell about your condition for anyone who has a condition. That's the first thing they look for when the rescue squad comes. And if no one's with you, that can be very helpful information that will be extremely helpful to your care. I had a call yesterday from a man who was calling me because he had an appointment with his doctor. He didn't know his social worker's number. He couldn't find it. He needed help getting to the doctor. And I advise him, as I advise everyone, with any medical problem, chronic medical problem, to keep a big notebook, and you put everything into that notebook. Now you can put it on your phone, but some of us lose our phones sometimes. Notebooks you can have in one place, you keep it there, you have everything in it. You write down everybody's name, their telephone number, you take it with you to the doctor, you take it with you any medical place that you need to go, and you have everything so that you know who to call, you know all their telephone numbers, names, in case you can't think of a name or whatever. Very helpful information. And for children, I would say to you parents, please teach self-management skills and start them early. We need to help every person become responsible for their own care, and to learn to, I teach little children who come to see me, I want them to know the names of their medicines and the milligrams, and I help them learn to pronounce those hard names, and to tell me how much medicine they're taking, and have the parents get them to take the medicine, but watch them, follow behind them, check that pill holder, and a pill holder is a really good thing, and because sometimes you'll forget, did I take that medicine or not? But you can look in your pill holder and see if it's still there, you know you didn't take it. Very helpful information. Encourage for children, encourage normal behavior as much as possible. Let them be involved in things within certain, within certain limits. This is so important to the development of the child in helping him realize his full potential. We have a camp for kids with epilepsy. We have a basketball camp that we have every year. My goal is to have them across the state, and I cannot tell you what this incredible coach does. He is a former coach with the New York Knicks. What an incredible job he does with those kids and how they evolve in even just 1 week. In doing things, and it's more about strength training than it is about basketball. And restrictions, when necessary, have to be tempered by common sense. And medical personnel really should be facilitators in helping families to be creative in individualizing limitations to needs. There is a program called WebEase. It's a web-based self-management program for adults with epilepsy that helps them set goals and creates plans and about dealing with stress and sleep and all those issues that you can look up Google WebEase and get involved with that. So how do we treat epilepsy? Well, for some people, we're actually able to do surgery. If you have seizures and they're in a really good spot, we may be able to go in and cut it out and stop those seizures, which is wonderful when that can happen. But not all seizures are in good spots. They have different types of surgery. The most common one is temporal lobectomy. That has like a 90% success rate. Extratemporal resections in other parts of the brain, about 50% success rate. Corpus callosotomy, sometimes people who have drop attacks, we will snip that little connection between the brain and keep that seizure being more of a focal seizure rather than a full drop attack. But let me say this to you right now. If there's any kids out there or adults wearing helmets that have not been tried on either Banzel or Onfi, that should be looked at because those two drugs have turned out to be extremely helpful to drop attacks. So if that's the situation, you want to ask your doctor about those particular two drugs. We now have stereotactic procedures. We can go in and zap spots using a whole different mechanism. We have hemisprectomy. Sometimes kids are born and have a major problem in almost half of their brain. We can go in and cut out at an early age. If we do this early enough, we can cut out that part of the brain and the other side of the brain will pick up the functions of that side. We have RNS, and this is a device that's come out just recently. Where we place a device actually on the brain and it monitors for seizure activity and it will stimulate, put an electrical stimulation to interfere with what is happening with that seizure and stop it before it spreads. And that's when we can't do anything else and nothing else is working. This is something that we try. We have the vagal nerve stimulator implant, and this is a little device that we put in the chest, and we wrap a cord around the vagus nerve, which stimulates that vagus nerve and goes off every 5 minutes. And you can tell when someone has a vagal nerve implant, their voice will change when they're talking. They will get very hoarse when this thing goes off. You have a magnet and anyone can swipe that device on the chest, over that chest and make it go off more frequently than 5 minutes if needed. If they start to go into a seizure, you could swipe that and make it go off. Some people we treat with diet, the ketogenic diet, the low glycemic diet, the modified Atkins are all diets that we use. And these diets are low sugar, high fat diets. And there's something about the fats that do something to the brain that make it calmer and is not as hyperactive with buzzing off in those seizures. And even the patients on these diets often can show improvement in memory and cognitive functions. So this is one that we also use from time to time, but it requires the person be extremely disciplined and extremely strict because even a flavored toothpick can throw the whole thing off. So you really have to be committed to do this diet. For most people, treatment is medication. It's the primary treatment. And thank goodness we now have more medicines. When I first started, we only had a few. We had phenobarbital, dilantin. That was pretty much it. And now we have a lot of different medicines. With medicine, about 60% of the people, the first drug we use, it completely controls their seizures. And then we'll have another 15% that we'll have to add another medicine on or try a different medicine. And then we still have about 25 to 30% of patients, as I mentioned earlier, that have a very rough time and have a difficult time with seizures. And we just don't have a good answer for them yet. We're working on it. And these people have very, very difficult underlying brain problems that make it much more difficult to control their seizures. Here are a list of the medicines we had since over the years. And we've got a lot of new ones that have just come out. And this Potiga has been discontinued. It was on the market and was very helpful for some people, but it had some side effects that they have taken it off the market. The Onfi I mentioned came out in 2010. This has made a major difference for a lot of seizures. It's a broad spectrum drug. It has been particularly helpful for drop attacks. It's helpful for partial and for absence even. Aptium is a new one, a new version of a drug that has turned out to be, created a few miracles in a few of my patients. The Epidiolex, I'm sure you heard a lot about Epidiolex. That one with CBD, it is the purest form of CBD. It does not have THC that makes you high in it. It is from the marijuana plant. They took a component out of the plant called CBD, and that has been helpful for some children, not all. It's been very helpful for kids with Dravet, very helpful for kids with Lennox-Gastaut, and some that have tuberous sclerosis. It has not been the least bit helpful for other people. So, but that has been a godsend for some patients. The other one, let me point out this, clobazam or Onfi now comes in a strip. So if you've got patients that have a lot of trouble swallowing pills or have trouble with liquids, then Sympazan is a strip that you can just put in the mouth and it dissolves instantly. It's wonderful. The newest drugs that have come out, one is Xcopri that just came out for partial seizures, but is also being looked at for primary generalized. So it looks like it's going to be broad spectrum. It will cover most of the seizures. And this one has had the highest rate of seizure freedom they have ever seen in a clinical trial. So we're very eager to see what it's going to do for some of our patients. Fintepla is a new drug that has come out for Dravet syndrome, which is a very difficult type of seizure that in the past has been almost impossible to control the seizures. So between Epidiolex and Fintepla, these children and adults are for the first time, getting a chance at seeing a much improved quality of life, which is very exciting. We've got different formulations and drug deliveries. We've got Diastat has been the primary rescue drug up until recently. Diastat is rectal Valium, but now this year and last year we just got Nasolam, which is a nasal spray of Midazolam, and Valtoco, which is a nasal spray of Valium, so that you no longer have to use the rectal version of these drugs, thank goodness, except for little babies and little bitty children. Everybody else would much prefer to have a nose spray rather than a rectal Valium given. So this has been a really big boost for rescue medicines, and these work extremely well for stopping seizures. Our goals of treatment is to have no seizures, no side effects, and to try to use as little medicine as possible, and then to look at rehabilitation and social adjustment. And in head injuries as well as in seizures, rehabilitation is so important. And I'm going to talk to you now a little bit about the psychosocial issues in epilepsy. And, after my first 5,000 calls, I published a chapter in a book and where I talked about being properly impressed with the impact that epilepsy has on a child or on their family or on an adult. It really has major implications in so many different ways. And in my first 50,000 calls, I published some information on what were the key issues in people with epilepsy because I track these and I publish on them and try to do something about some of the issues that come up that need to be addressed. How do people find out? Well, doctors are my top source, pediatric neurologists being number one, and then other patients tell people, and then some people find out about us on the internet and other ways. As I said before, I keep a call sheet as to where people call from and what their problems are and what the concerns and issues. Interesting that 4 women to every 1 man call. Men just don't tend to call. Uh, the most common caller I get is a young mother of a child with epilepsy. And I get 2 basic categories of calls. I get newly diagnosed, scared to death people. And then I get the people calling who are having a really bad time or their child's having a really bad time and they're looking for something new, something better. They're looking for better help for their child or themselves. The interesting thing about epilepsy is it ranges such a broad spectrum so that when you go marketing about epilepsy, it's really hard. If you market for one end of the spectrum, the other end is saying, "What are you crazy?" That's not what epilepsy is. But one of the, epilepsy can be like this child who has brief little absence seizures, who's going to grow out of them, who's going to even forget he ever had them. He won't even know he had them. He's going to grow up and do whatever he's going to do. On the other end of the spectrum is this child who has a progressive myoclonic epilepsy, whose mother called me from Scotland. And that child has a very, very serious deteriorating brain problem. And my work with her is to help her in her grief process because this child was going to die in 6 months. That's the other end of epilepsy. You have people with very severe problems. The good news is that epilepsy actually, the majority of people with epilepsy are like this young woman who has a partial seizures, focal seizures, who's well controlled. She just had her second child. She's functioning and doing well and takes medicine and goes on about her life. I find that there are different stages in adjustment to any traumatic thing that happens to any of us, including epilepsy or head injury. And I'm sure many of you can attest to this. The first stage is shock or disbelief. I mean, who ever dreamed they'd be in a bad car wreck or have an injury of any sort? Whoever believed that they'd wake up one morning and have epilepsy? I sometimes see denial, especially in patients with epilepsy or their family members, is that this isn't epilepsy, this is something else. They made a mistake. I'll see them. Teenagers are really good at denial. They don't need that medicine. They don't have a problem. I even see bargaining. I have people trying to make deals. Um, if you take this away, I'll never smoke again. That doesn't last so long, but we all do it. All of us try to make bargains about things in our life. I see incredible fear. I see a fear that gives mothers um, the ability to hear the slightest noise in a bedroom 4 doors down. And I sometimes see anger. I see people being very angry about their disorder. They're angry at the doctor, they're angry at the parents, they're angry at whomever, they're angry at their husband or wife, just full of anger. They did not want this. Um, and I always understand anger, you know, anger. And if you will address those caretakers and professionals that are hearing this, one things I learned over the years is I don't respond to anger. I look for the underlying feeling because anger is always a cover-up feeling for pain and vulnerability. So if you address that feeling rather than the anger, it will help you a great deal. I see guilt. Mothers in particular are really good at guilt. It must be something they did, something they didn't do or did or whatever. Or is it, guilt at yourself? You must have caused this for some reason. I see a depression. I see a mourning. I see a grieving. Who amongst us ever dreamed that we would have this situation to deal with? And it is painful. And there is a time of grieving that isn't recognized as we come to some new identity. There is an identity readjustment. You were a person who did all these things before, and now you are a person who has a disability. And there is an identity readjustment that comes with that. Most people, many, not all, come to some level of acceptance in time. And some people take this and do something with it. They even go out and I had a mother of a child with severe seizures that went out and started raising money for research for epilepsy. That's the way she dealt with it. And I've seen many things like that. They take this problem and they try to help other people. I have a mother on my board that when her child developed this, and she found out that I was helping people who couldn't afford their medicine. She said, I can't imagine not being able to buy my child's medicine. And she immediately went out and started raising a lot of money to help our medication fund. She and another gentleman who was lucky enough to have seizure surgery. And he showed up at my first big chili cook-off fundraiser carrying a bag. And he handed it to me. And he said, here, Pat, in here is all the money I would have paid for medicine last year. I want you to take this and buy somebody else's medicine with it. He had been one of those lucky ones who had been able to get off of all of his medicine. But instead of just going about his life, he thought of other people and he saved all that money and put it away and all the time giving us big money for our medication program. Sometimes when things are really bad and can't be fixed, I will see almost a chronic sorrow in the person or the family or the caretaker. I sometimes see post-traumatic stress syndrome, both in the patients and in the parents or family members. It can be very traumatic to cope with a serious chronic medical problem. And this needs to be addressed and needs to be helped. Uh, David uh, Taylor from Wales wrote years ago, he was the first to write about the predicament of epilepsy, and he said, how any given predicament is being experienced depends on the personal history of the person. This personal history that is different from the history of the disorder becomes a crucial aspect of diagnosis. Who comes to the injury determines a lot about how they deal with it. What their own personal history has been in their life determines a lot. And all of us come into things, with different strengths and weaknesses. And that helps determine how you're going to do in dealing with any major trauma. I identified the top social issues in my first 50,000, quality of life, and I'm going to go through all of these. Is number one, of course. Everybody wants a decent quality of life, don't we all? This study was done by WHO, World Health Organization, And they ask a bunch of professionals a lot of questions about epilepsy and epilepsy treatment. And then they ask patients, patients are in red, the same questions. And they were all about the same except one area. And that one area was social burden. When they asked the doctors and the healthcare providers, how big a problem do you think social burden is? About 23% said, yeah, this is a problem. But hey, look at what the patient said. 79%, almost 80% of the patients said social burden was a major problem for them. So there's a disconnect sometimes in what we see as the problem and what the person with the disorder sees as the problem. There are certain factors that affect the quality of life in seizures, and I suspect it's the same in head injury by itself. The presence and extent of abnormality in the brain and its location, and having other handicapping conditions. How severe was that head injury? Where was the head injury? Makes a big difference. The type of seizure, the frequency of seizure, and the length of seizure makes a big difference. Compare those little brief absences that are nothing that you hardly notice to the big tonic-clonic or atonic seizure. Boy, what a difference in quality of life that has. The anti-seizure medicine, anti-epilepsy seizure medicine drugs, side effects make a big difference. There are some side effects of our medicines that cause big problems. We have some medicines that cause mood disorders, cause depression, cause cognitive problems, and this can make a big difference. I've had patients tell me they would rather have the seizure than have some of the side effects. And if you know of someone or you have some of these side effects, you need to talk to your doctor about changing your medicine. Or if you don't know these are side effects, call me. If you're having mood issues, rage things, this could be coming from the injury itself, or it could be helped along by some of the drugs that you're using. And we're getting better drugs all the time that don't have some of these side effects. So that needs to be addressed and needs to be looked at. What age it comes on, when it comes on as a little baby and you don't know much different, or did it happen to you when you were 13 and you were in the cafeteria with all your friends, that first tonic-clonic seizure? What kind of family you get put into determines everything for all of us, doesn't it? And the stability of the family and the parenting styles, the parents who completely dominate and won't let that child do anything and teach it that it's very disabled, can make a big difference in that quality of life compared to the family that is supportive but yet is helpful and teaches, self-management and that sort of thing. Your own perception of the disorder makes a big difference. And I did a 20-year project looking at stigma, going in and teaching every fourth grade student in Forsyth County, trying to change the whole world perception of epilepsy. Because, it's how you feel about it, how you see it. I teach that this head injury or seizures or whatever is just another medical problem. It isn't something you should be ashamed of. It should, this is just another medical problem, and all of us can get one of these at any time, and to look at it differently. What kind of community you're in. I see such differences, like in schools. I'll have some schools that are so supportive and helpful, and the kids are wonderful, and then I'll have others that just, they're bullied and just have the worst community environment, and what a difference that makes in your quality of life. Um, Remember, with epilepsy, same with head injury, most of these problems are not coming from the seizure itself, but from that underlying pathology. It's what's under there that's causing all the problems, including the seizures. And one of the biggest issues, I think, for most people with seizures is the unpredictability. And nobody said it better than this young woman from England. If we could schedule seizures at 3 o'clock on Sundays, what a difference it would make for all of our lives. It would be predictable. You'd know what to expect. it's that unpredictability that is the hardest thing of all. One of the big issues, and I spend my days working on this, is the cost of epilepsy. It is an expensive disorder to have. It costs a lot of money. Our drugs are expensive, our tests are expensive, our doctor costs are expensive. And this study done by Andy Wilner, had the great fortune to be able to go into one of the managed care programs and look at the actual cost of what they were paying for things. And it shows that the people with epilepsy cost a lot more. In 2007, Harvard did a study that showed that 62% of all personal bankruptcies, 62% now, of all personal bankruptcies were because of medical costs, and that neurological costs were the highest. And 3/4 of those people had insurance. Uh, and I can attest to this. I get calls every day with people with insurance that still have incredible bills to pay, even with insurance, that are not being covered by insurance. I can tell you that last year I paid for prescriptions ranging $68 a prescription to $3,100 a person for 1 month. And this is a serious problem. We can't even begin to pay for those medicines that cost $18,000 a month. Some of these medicines are exorbitant. Driving is a big issue for people with seizures, and I don't have to tell any of you what it means not to be able to drive. You just think about in your own life, if you couldn't drive, what difference this would make for you. And I can speak for North Carolina. We don't have a really good public transportation system everywhere. In fact, we don't have many places with a really good transportation system set up. And so people who suddenly develop seizures and all of a sudden, have a job that's like an hour away, what do? It creates a major problem. And study after study has shown, Frank Gillum in his study showed that driving was one of the top issues for adults with seizures. Employment can be a problem, although we have laws on the books in our state that say you are not supposed to discriminate against people with any kind of medical condition. It happens all the time, and people with epilepsy do have a harder time with employment. Education is a problem. Children, especially those with intractable seizures, but even kids who don't have intractable seizures, are at special risk of learning difficulties. Common problem. Bruce Herman did a wonderful job looking at this, and he actually found that a lot of the kids with epilepsy had these problems before they were ever diagnosed with seizures. They had cognitive issues showing before the seizure showed up. They had psychiatric complications before the seizure showed up. So it just is that underlying cause is causing other problems. And early intervention is crucial. Early referral to rehab programs and any kind of community resource should be a priority. Vocational rehabilitation, refer to epilepsy camps. Early referral to any program you can find out there. And sadly, a lot of our resources have been much reduced. I'm hoping and praying that our future starts to look better. Injury is a big concern of parents, injury and death, as I mentioned. And people can get injured in seizures, a lot of head injuries, a lot of burns, scalds, teeth knocked out, dental injuries. And we especially get worried with seizures and bathing or swimming. And people with seizures should always take a bath when somebody else is home, and be very cautious about swimming. Should always swim with a buddy, and if they're having lots of seizures, wouldn't swim at all. But the amazing thing in this one study of patients with seizures, 65% of them had had no injuries. That's an even more interesting finding. So safety admonitions need to be discussed and thought about and worked on, and always thinking about how can you avoid having problems with seizures, and they should be tailored to the seizure type and frequency. I would urge those of you working with epilepsy to always be mindful that people with developmental disabilities, including epilepsy, experience greater risk of becoming victims of violence and abuse. And it's pretty impressive, some of the studies. Please watch for that, and please watch for symptoms of that. Please be a hero for these people. Other common issues I find in epilepsy, and I am sure these are the same with head injury, and that is high rate of depression, high rate of anxiety, memory problems, and cognitive issues. These are common issues that we find in epilepsy, and I have no doubt it's the same for head injuries. Stigma, as I mentioned, is alive and well. I'm sorry to report. As long as we have people, I guess they'll always have a need to make fun of other people, or it's fascinating how all that works. And as I mentioned, I did a study. I've worked on this for 20 years by teaching children, fourth grade students, about epilepsy in a positive way, trying to change that. And I would love to pick that project up again and do more with it. It's so needed. The thing I've noticed now, while people are much more open and don't have as many ignorant ideas as they did back when I started, we are much more effective now at bullying. With social media, we can just do all kinds of things, mean things to people, and with little responsibility. We've taken that up to an art, I have noticed. Resources out there, there's not as many as we had at one time because of the recent years where we've lost a lot. I'm hoping that's going to change. But let me point out that one of the biggest resources of all is within that person, and helping to tap that potential that is there, often untapped. Just letting people know that they can do things. And I always, in a lot of my talks, especially with health professionals, I remind them of the power of their words. Words are powerful. And I encourage them to think about what they say and to go out of their way to say positive things to the people they serve. To say to young people that may not have anyone in their life that would give them this thought. Have you ever thought about going to college or community college? Have you ever thought about getting trained in such and such? Just that thought, just you saying that to someone, giving them the thought that they could do that when the whole world has told them that's not for you. That's not possible for you. Or saying to a mother of a child with so many problems, what a wonderful mother you are. You do such a good job. That will carry her for months. These things are so needed for all of us. Just remember the power of your word. Um, and I'll tell you this quick story. I had a doctor say to me, he said to me, Pat, someone said to me the strangest thing today. He said, and I have no memory of this whatsoever. He said, a father, actually, he was another doctor, said, I need to tell you something. You won't remember this, but 20 years ago, you saw my son. And he was about 8 at the time, and he was having migraine headaches. And when he came to see you, you lifted him up and you put him on the examining table and you looked at him and you said, Jonathan, do you know why you have migraine headaches? And he said, no, I don't. And you said, and the doctor said, well, I have migraine headaches. And the reason you have headaches is that you are so smart. That's why you're having those headaches. And we're going to try to help them. We're going to do some things here and see if we can help those headaches. but that's why you're having headaches. I just want you to know. And I laughed because I'd never heard anybody say that before. And the doctor said to him, "You didn't know this at the time, but my son was having great struggles. He had a learning disability and he was having great struggles. And we hired tutor after tutor to help him. And as time went on, when he would cry and say, 'I can't do this,' we would always remind him what you said. Now, Jonathan, Dr. Smith said that you have, you're really smart in that and that you can do this." And he said, "My son just got his PhD, and I credit you with that." And I think, what a remarkable thing. The power of your words, the power of you saying to someone, "I believe in you," or "You can do this," or "I will be with you as we do this." What a difference that can make. We also have the power to destroy. And I could tell you some story after story of how effective that's been for people. But we don't have time to go into so many stories. Um, I want to end by giving you this quote that was given to me by a doctor visiting me from Germany who had, it was given to her. She knew I liked to collect quotes, and it was given to her by a patient dying of cancer. "I think illnesses are keys that may unlock certain doors. I think there are some doors that can be unlocked by illnesses only. In any way, there is a state of healthiness that hinders us understanding. Perhaps the illness may show us some truth, which healthiness hides away, so that it makes no difference anymore. Among those who are enjoying a complete and undestroyable healthiness, I until now have met none who is not some kind of poor, like those who've never traveled." That always reminds me of people with epilepsy and what they go through and what they learn. And I do believe there are gifts that come with every bad thing that happens to us. There are things that we learn that we would not learn any other way that help us to go on and do better in life. So, and I can tell you that I have seen my share of miracles with patients that I thought I would never see controlled, that I would never see uh, not having seizures, and now they're seizure free and with a different look on life. And before you guys start to look like that, I will come to an end and be glad to take questions if I can figure out how to get back on.
Thank you so much, Pat. That was really just excellent, wonderful information. We do have a few questions. For any of those of you who have not gotten your questions in, go ahead and put it into the questions box and I'll relay them. So the first question that we got was, how should school staff and parents respond differently to children with autism, low cognitive function, or nonverbal language when they're having a seizure?
Now, say that again.
Yeah. So, how should school staff and parents respond differently to children with autism, low cognitive functioning, or nonverbal language when they're having a seizure?
How should children respond to them?
How should
Um,
school staff
well,
and parents?
school staff, the first, I'm trying to find my way here. Um, Stop showing screen. I'm trying to get back to you guys.
We can see you if that
You can see
helps.
me? Okay,
Yeah.
I just can't see you. Okay, you can see
Yeah.
me. We're okay. Um, that's why I did that project with fourth graders, because I wanted to teach children how to respond, and I wanted to talk to children and the teachers about how about how this response is. And I have to say, I would actually love to. I have a whole talk on that project and what I found and what I learned, and it was amazing what happened in just going in and teaching children and teaching them to be kinder to other people and be more understanding. And I can't tell you, um, I had a child after that class, the teacher told me the next year, that was in a grocery store when someone in line in front of her had a seizure, and everybody panicked. Everybody went running off in all directions, screaming, carrying on, get help. And oh, good, back up. And that little girl held up her hand and said, "It's okay, it's okay, it's just a seizure, and I'll tell you what to do. Number one, stay calm." She went through the whole list of first aid, and everybody was in shock. Here's this little kid telling them what to do. And it was amazing to me how beautifully the children responded and wanted to help and would chide the adults, because I told them I was there looking for teachers to help me make a difference in the lives of the kids with epilepsy and what we could do. But that they should not treat any child any differently when they're having a seizure. You don't. It is up to the adults to do a good job explaining what is happening and explain it in a way that makes it positive, and that this is something. This is just a normal behavior. It's just a seizure. Let me tell you what it is. And now Johnny is having a seizure, and anybody can have a seizure. This is what I point out to everybody. Anybody can have a seizure anytime. And that's why it's so important for all of us to know about seizures. And here's what you do. And you teach first aid. That's a wonderful teaching moment. And let them know now he's going to be very tired and sleepy when he comes out of this. It's dependent on the seizure, of course. But and that's why I spent so much of my time in the school with teachers. And I did teacher workshops as well, and would love to do more of these. I need to do more of these, and to try to teach kindness is as important as the medical part. And I did that with the children by teaching them what a difference. And I would use examples with them. How does it make you feel when somebody says such and such? What would you do? And then I asked them, what would you do if someone had a seizure? If I had a seizure right now, and I always put it on me. If I had a seizure right now, what would, and kids are making fun of me, what would you do? Well, I can guarantee you there's always some little kid that stands up and says, I would tell them not to do that. You've got your heroes in every class. But I set it up so that I find those and get them to speak about this. Um, but and I don't know if that person has, it's specifically who asked the question, if they've had things happen that were unfortunate, or was there some way they were treated that was different or something. But I am in this state. I train a lot of the school nurses, and and I would love to reach as many of the teachers as I can. It's gotten harder to get to them. I mean, even before COVID. There was one year, many years ago, I did workshops in 90 counties in this state, going county by county, just speaking to teachers. And what happened is I found a lot of kids, when I do that, when I do a workshop in detail and I go through the seizures in detail, within 30 to 60 days, that information helps find somebody out there with seizures that wasn't diagnosed before. I have had that happen over and over. The information that I give, it ends up helping somebody know more about this, or they get them to me. We'll get them on a different medicine, or we get them diagnosed, or something. It makes such a difference.
Yeah, that definitely, I think the information just even that you shared today was so powerful, we're getting a lot of great response for it. Can you mention can you say the 800 number again? I can put it in the chat.
It's 800-642-0500.
0500.
Mm-hmm.
All right, that should be in the chat for everyone to see as well.
It's
I have a
got
question.
the Epilepsy Information Service at Wake Forest.
Perfect. I have a question here. Can seizures occur when someone's sleeping? Maybe
Uh,
it's something that sounds
the
similar
most
to
common
sleepwalking.
the most common time for seizures to occur is upon going to sleep and coming awake. that it actually seizures in the sleep is actually the most common time to have seizures.
Does it
There's
often
something
look like
our brain, as
sleepwalking?
our brain goes through different stages of sleep, there's a certain stage that's very vulnerable, and it's usually sometime after going to sleep, you reach a certain stage and you're very vulnerable in that stage if you have a tendency for seizures. So that's when it usually happens, either going to sleep not long after or upon coming awake. We'll have common or upon an arousal during sleep at a certain stage. It's the stage of the sleep cycle that is vulnerable. And you know, we go in up and down in our sleep cycle all through night. We have arousal.
Gotcha. Yeah, very, very interesting. One question we have here, is there a correlation between PTSD or post-traumatic stress disorder and seizure disorder? Kind of similar with that, someone mentioned that they've had a family member that has PTSD and seizure-like symptoms when they're asleep.
Yeah, that's a really common problem, and I have a special interest in non-epileptic seizures. It's called psychogenic non-epileptic seizures, and people who, especially I mentioned before, especially mild head trauma, and it could be severe head trauma too, but mild head trauma predisposes people to this type of seizure. And there's a lot we don't know or understand about it. And there's a lot of ignorance about it too. And I actually have a whole talk on that I do. And I'm working with a woman in New York. We've done, actually, we're working on a Broadway play that has a teaching thing about this. And I hope and pray she gets the funding to produce it. We have done this. I'm going to bring it to North Carolina as soon as the pandemic is over. And I will be glad to share that with you, Lauren, when we do, because I wanted, she called me a few years ago and she told me about a new type of therapy that she had that had helped her. She realized, and looking back, she was my patient years ago and she stopped having seizures when she was 17. Looking back, we now wonder if what she had was non-epileptic seizures due to a major trauma as a child, major trauma as a little girl, when she was about 5, of which she had no memory of. And only in therapy did this start to come out. And she had this type of therapy that was very helpful and had made a big difference. And I do a national training program for epilepsy doctors and nurses. And I thought, because this is such an issue in our monitoring unit, we have a lot of people with non-epileptic seizures. I thought they needed to know about this. So I asked her with trepidation, I asked her if she would be willing to come and speak to my national conference. And she said, let me think about it. And then I realized I'm asking a very difficult thing to ask of someone to share personal things about their trauma. Uh, and I felt kind of bad about that. But then I knew she would feel comfortable saying no to me. But she called me back in 3 days and she said, Pat, I sat down and wrote this up as a reading. If I could get 3 Broadway actresses to perform it from me at different stages, would that do? And I said, oh yeah, well yeah, I would. That would do. That would be interesting. It was an incredible experience. She got a standing ovation. Then we took it to Chicago and did it for the medical students at Rush. We took it to New York. We did an off-Broadway thing about it. But it is a really big problem and common problem in people with and without head injury. There are a lot of people that have been abused in different ways that have it's coming out in the form of a seizure or other physical symptoms. You know, the body mind is closely connected. It's not a separate thing, and anything that happens to us, you know, can change our brain and cause different kinds of symptoms. And so we really want to. I want to bring this to North Carolina, and I pray that she can get funding and put it on Broadway because it will help a lot of people. What she's able to bring, and she's a script writer. That's her job. She's a wonderful, wonderful writer.
Yeah, it sounds like a really interesting project and definitely a creative way to express something that like a lot of people deal with and a lot of people are, more awareness could be given. So definitely let us know if we can help at all, even if it's, maybe we record
You
it and
I
put
just
it
need to
out.
find funding. It's kind of hard to find funding for something like that.
Yeah, yeah.
Um, and that's that. I'll bring the actresses here, and I will. And what I'd like to do is take it to Raleigh, to Asheville, to Wilmington, and maybe Greenville, because I think it's really an important topic to be discussed, and
Yeah.
to let people know that they have the ability to to get help and to change and not have to suffer so much.
Absolutely. We have a question here asking, how does one differentiate between psychogenic and epileptic seizure activity? Is it just through monitoring?
Excellent question. By looking at the seizure, I can tell you that years ago we took two of the leading doctors in the world. I was at a meeting in Norway, and we put the seizures up on the screen with no EEG. And these two very knowledgeable doctors looked at the seizures and had to determine, are they epileptic seizures or non-epileptic, and they were wrong 50% of the time. So you can't always tell by looking at the event that it is not epileptic. We often have to bring them into monitoring units and hook them up to EEG, and let them have their events on EEG. And if it's a non-epileptic event, nothing shows on EEG. And there are some people that have both epilepsy and non-epileptic seizures, which makes it tough. And we try to help them distinguish themselves, try to help them learn how to determine which is which. But both seizures, epileptic and non-epileptic, are both triggered by stress. There's triggers for both of them.
Gotcha. Yeah, definitely. It sounds like, I mean, just the body, the mind, the head, the actual brain, everything is so
It's
interconnected.
connected.
And
It's all
yeah,
connected. There's some great books. There is a great book on this. In fact, the woman is giving us the money from that book to set up our scholarship for non-epileptic events, people with non-epileptic seizures, and it's called uh, Psychogenic Non-Epileptic Seizures, a guidebook. And it's a great book to read about it.
yeah, excellent, excellent resource. We have a question here. Can you suggest any adaptive devices for seizure alerts other than VNS when a person is sleeping?
Well, now there's several things that we have. We have smartwatches. Now, this is mostly for, it has to be seizures where there's lots of activity, because if you're having something that's very subtle, it ain't going to pick up on that. But there's Apple Watches that have a seizure detection thing. There's a one called Empath. Um, there's several of them. In fact, I've got a handout on that. Watches that you can get that will alert someone else that this person is having a seizure. One of the problems with a lot of the watches is they do a lot of false positives. So you get alerted when they're not having a seizure, which is pretty soon it's like, this is a bit of a problem. There's also a bed, I think, MFit bed monitoring that goes on the mattress that picks up activity in some cases. There's several devices like that that we have that are able to help detect seizures. And then there's seizure alert dogs, but a seizure alert dog has limitations. They're also very expensive, and we have some videos of the dog sleeping through seizures on our monitoring unit, so they don't always alert. And so they alert you, and some people, they can help them know to sit down or lie down if they're going to, if they're about to have a seizure. But um, many animals are quite sensitive to people and their moods, and issues and things. But the seizure alert dogs are really quite expensive.
Gotcha. Yeah, I've seen a lot of those, out in grocery stores or, I've seen, videos where they are really helpful during the night. But yeah, it makes it not as accessible with the cost amount.
Yeah.
Um,
The seizures and the watches, they alert someone. They can call someone, or you put in who to contact, and they can alert that person.
yeah, that seems like a really good. I know that then they now have like fall detection on there too, so definitely that type of it's good to see the
Oh,
kind of
pretty
mainstream
soon we're,
devices.
pretty soon I predict we'll all be wearing complete monitoring outfits on all of us that will watch after our every breath. It's amazing what technology is has done.
Yeah, sounds about right. Sounds about right. And then, so I guess about one more question I'll throw in there um, is there's a lot of similarities sometimes between autism and brain injury, but is there someone's asking specifically about what is the connection between autism and epilepsy? Do you see a correlation or trend there?
Um, Remember, autism is coming from an underlying brain problem, and so is seizures. And whatever that underlying brain problem is may cause autism, learning problems, headaches. I mean, in fact, a large percentage of people with autism do have seizures. I think it's about a third, as I recall. Um, and it's all everything is determined by the underlying brain mechanism, whatever that is that's causing autism can also cause seizures, can also cause different other issues. It's all determined what the problem is and where it is in the brain as to what is caused, what your symptoms are. Because some people will have seizures and they'll have very minor seizures. They cause almost no problem otherwise, and they lucked out. And then other people will have seizures maybe in the frontal lobes that causes executive function problems. It depends so much on where the problem is as to what it causes. What it it can cause. I have a kid that has a problem with some of the tissues. He has a cortical dysplasia, and that means that when the brain was being developed, some of the little cells set up housekeeping in the wrong place. That's a very simple way to say it. And he's got tissues where there shouldn't be, and they're causing problems. And he has autistic-like traits. He has seizures, and he has total lack of facial. He can't recognize anyone's face. You know, so that whatever problem in his brain, it's in that area that involves those areas. See, so it all depends on where the problem is, and how it's set up as to what causes that problem.
Thank you, Pat, for just the information. We're getting a lot of great feedback here and just really people excited about it. So let us know in the comments if you want us to do a part two. I'm sure it sounds like, I know Pat's got so much information to share and we're happy to give that opportunity. So when you're filling out the surveys, let us know specifically and we'll try and get it out there for you whichever way we can. We'll try and get the PowerPoint onto our website, the slides, so that you can be able to access it. If not, we'll see what else we can try and
And
do. If you have any additional questions, feel free to contact me. And then I also have Pat's info if you're wanting to connect with her directly. She mentioned that she has specific resources and handouts and education materials. If you have any specific questions, I can send her over your information and we can get you connected. So I look forward to seeing you at the next one. Thank you, Pat. Everyone have a wonderful
thank
day.
you, Lauren, for what you're doing.
Absolutely.
Take care.